From the White House to community clinics, what happens next for healthcare reform? Reporting on Health has brought together an expert panel to offer insights, story ideas, and predictions on the road ahead for healthcare in America. On the panel, Mary Agnes Carey, a senior correspondent at Kaiser Health News; Tom Miller, a resident fellow at the American Enterprise Institute; Judy Waxman, Vice President of Health and Reproductive Rights at the National Women's Law Center; and Anna Gorman, a staff writer at the Los Angeles Times, where she writes about public health and health policy. Mary Agnes Carey begins the webinar with an overview of the Affordable Care Act.
On the 28th of June, the Supreme Court ruled that the individual mandate, this provision that most Americans have health insurance by January 1st, 2014 to pay a fine, that could stand. But they ruled that the law's Medicaid expansion, that states do not have to do that if they don't want to and they don't risk all of their federal Medicaid funding. That was the question. That's what John Roberts called the gun to the head, the requirement that states had to expand up to 133% of poverty or risk their federal Medicaid funding. As we know, on Tuesday, with the election with President Obama being elected and Democrats keeping the Senate and Republicans keeping the House, that implementation of the health law now moves forward. Governor Romney, as the Republican nominee, had threatened to repeal the law, and even if he didn't have control of both chambers, there were thoughts he could do things to slow down the implementation, but that threat's now gone. One other deadline I should have added there is 2014, or when two key provisions of the health law start. Those are the health insurance exchanges and the Medicaid expansion. Okay, moving to the next slide, implementation challenges. It's important to note that just 13 states and the District of Columbia have passed authorizing legislation for the health insurance exchanges. And by November 16th, states have to say whether or not they're going to set up their own exchange, and not only whether they're going to set it up, but how they're going to go about it. Now, there may be some flexibility on that from the federal government, but that's the deadline that exists now. If a state doesn't set up an exchange, the federal government is going to do it for them. And now that the election has been decided, you may have some Republican governors who were hesitant before about whether to set up a health insurance exchange or do the Medicaid expansion. They may decide to go ahead with implementation because there is no there's no apparent thought that the law would be repealed for any reason because President Obama was reelected. That said, Republican and Democratic governors are still concerned about how they pick up their share of the Medicaid expansion. As you may know, the federal government picks it up for 3 years at 100%, and that eventually goes down to 90% from the federal government. So an idea for you is to look at your state. Is your state moving ahead with the exchange? Are they moving ahead with the Medicaid expansion? Are they trying to decide what to do? Even with the election results, are they firmly against doing either? Looking at that and explaining it to your readers, I think, would be a really good story. Okay, so moving to the next slide, political hurdles. There are still a fair amount of political hurdles on Capitol Hill with divided government. As you may know, House Republicans have voted 33 times to repeal the entire health law or sections of the health law or to defund the ACA. I think in the next Congress what you'll see is that Republicans will have a lot of committee hearings in the House for oversight. This is where they subpoena documents from federal officials. They'll be looking at the distribution of the subsidies, how the exchanges are working, the Medicaid expansion, to find flaws, to find problems they see there. And I think that Republicans will also push to try to stop or reduce funding for implementation of the ACA. Of course, with a Democratic Senate and a Democratic White House, those efforts are going to be rebuffed. But nonetheless, I think House Republicans will try to reduce the funding. You've got to remember also that the health law remains unpopular with the public, and in particular that individual mandate requirement is very unpopular. So that also will shape as things go forward, and the administration really has a sales job on its hands to convince people that the ACA is a good piece of legislation, something they'll benefit by. There's no doubt that people like a lot of the provisions that are in place right now, whether it's covering kids up to 26, or you can't discriminate against a child based on a pre-existing condition, or the upcoming requirement in 2014 that insurers must cover all comers and cover all conditions. People like those, but overall there's still very heavily split opinion on the health law. And then I just want to throw in one note about the fiscal cliff. This impending mix of expiring tax cuts and the automatic spending cuts known as sequestration. The thought is, to deal with those as part of a larger budget package, that Congress might look at changes to the ACA as part of that. There may be some changes, some scale back on the subsidy levels, or changes to taxes on medical devices and the insurance industry, for example. But I don't think Democrats would move on that unless Republicans moved on higher taxes as more revenue, and they have not yet been willing to do that. So if we go to the next slide, called possible implementation delays, rather. Again, there's that question about, will the Obama administration delay the ACA implementation of the health law? Exchanges in the Medicaid expansion are scheduled to start in 2014. Now, if they did a delay, that would help save billions of dollars for a larger budget deal. It could provide funding to stop these automatic cuts I just talked about, known as sequestration. It could theoretically give states more time to implement the law, and that would mean a smoother rollout, but it would delay benefits to millions of Americans. I think that's a political risk because you've already got people waiting to 2014 to see major provisions. And to be clear, the administration has said the law will be implemented on time, and I've had many Democratic sources say that any implementation is just fantasy talk from Republicans, that the law will move ahead, but we'll see how it plays. And then there are other pressures to talk about when you look at the healthcare law. Is the penalty for purchasing coverage too low to induce people to enroll? Might they look at a penalty of $95, for example, is what it is in the first year for an individual? Will you have people say it's just cheaper for me to pay that penalty than to enroll in health insurance? I think you have to look at the same thing for employers. There's a provision in the law that if you have 50 or more employees and you don't offer insurance, and one of your workers gets a subsidy and goes into that exchange to get coverage, then you are going to be subject to a penalty. And so will employers look at that and say it's just cheaper for me to let my people go into exchange? I don't offer them health insurance. They get it that way, and I pay the penalty. Will they make that calculation? And so looking at those 2 points, that is an interesting story idea for your readers. What are people in your state, in your area doing? Are individuals considering just paying the penalty? Employers right now are working through these issues. What road will they take if they currently offer insurance? Will they continue doing it? And another note of skepticism here that people have talked about with the ACA, the Affordable Care Act, is it does make a lot of changes in Medicare provider cuts to hospitals, to nursing homes, and other providers. The thought has been, will counter pressure from these groups that are often very politically powerful, will that push back, stop those cuts that are planned? But there's been skepticism that the cuts, which are over $700 billion over a decade, that they'll go forward. And so finally, I'll just close with the idea that there's also concerns about there won't be enough people in the healthcare workforce to handle up to 30 million people that will now have insurance under the ACA. You're talking about physician shortages, nursing shortages. That's a great story for you to pursue. How are hospitals and clinics and physicians and other healthcare providers in your area bracing for this increase in newly insured people? And I'll leave the last slide. You can look it over. The ACA does a lot of things to try to address this. They give more money to community health centers. They have all sorts of new graduate medical programs and so on. You can look through that, but looking at those areas individually in your area, I think, would be very helpful. Thank you.
Guys, I have to keeping up with the slides here. But we're going to go now to Tom Miller, and we're going to take a moment just to get his slideshow up. But Tom, can you maybe say hello, and I'm hoping we can all hear you.
Sure. It's a pleasure to be with you. I don't know whether to say good morning or good afternoon, depending upon what time zone you're in, but whatever time works for you, that's fine. And when we get the slides up, I will say advance, because other folks have preempted the phrase forward, I believe.
Yes, so we have the slideshow up. We have your title page. I'm going to advance to the first slide, Storylines to Pursue.
Okay, and this is a quick thing that you're probably most interested in, and we'll go into some detail. Some broad outlines of some general themes you might want to look at. The first is obviously the cross pressures on what are said to be the state-based health benefits exchanges. Will they be more or less in one direction or the other? Market facilitator, more of a road to an integrated system of similar regulation and benefits contours. And whether, we're going to have a split among the states to different degrees. The more enthusiastic blue states out in front of the pack, whether it's 12 or 13, that will have some version ready to go, but a lot holding back. We just had some news coming in the last, I think, hour that Bob McDonnell in Virginia says they're going to default to a pure federal exchange. Beyond the exchange issue, the next one up is recalibrating the Medicaid expansion. There is some degree of state bargaining leverage post-Supreme Court decision, and the real issue is what's sustainable despite the way it's been set up under the current grid. Will this be a bit of a metabolic disorder of more and more fast food spending into Medicaid, or perhaps the equivalent of fiscal bulimia, where we do a little bit of a binge purge in light of other economic and fiscal conditions. State-level politics is an important topic to think about. You still have 30 Republican governors and similar state legislators, so you do have the political battle moving less in Washington to a balancing act between the states and the feds to different degrees, at least on the margins. And what this is really all about is setting the table for what's going to be a pretty massive stress test of a new system not fully tested out in 2014. Whether that's January 1 or slightly later, we'll see. But the mechanisms to work will certainly have a lot of updates along the way. Along the way also, we'll be seeing a new load of exchange and other federal rules fleshing out essential health benefits, which will be downloaded in the next month or two and probably give you a better flavor for where the administration wants to take its first shot and how far it wants to push what it can do under the law even further. The other thing I just threw out as an aside, I won't get into it in any detail, is whether we can in fact have the promised transparency without real prices. We're going to have some type of price signals that are either bundled, subsidized, or in larger organized entities, not necessarily at the level at which patients normally think about what they would want to know, and whether that happens through exchanges in a more aggressive way of providing information, or states as a source of some of this information. We'll see. Let's advance to the next slide after the storylines to pursue, which is primary political scenarios. Several of them have been removed, I've noticed lately. So the post-November playing field, certainly not going to be rejection. Ratification is a matter of interpretation. I still bet on equivocation. So we've got re-election for the president without full congressional control because of the House Republicans. And the question is whether the White House moves from what in the post-enactment stage was more of a rope-a-dope strategy to let their opponents keep punching but not knocking them out, to more of a survive and advance. The other question is whether there will be more of a full-strength version of what the administration most wants to do with the next round of regs, a little stronger, or perhaps a reality-based revision to have something workable and then worry about extending it to further degrees in later years. The other thing to keep and remember is Pottery Barn rules will be at work here. I don't think Republicans are going to embrace this because they'll take the stance we just saw in Virginia. You break it, you own it. You're going to own what comes out of the system for better or for worse, and that'll probably be the default option for many of those folks. Let's advance to the next slide. The primary political equation, particularly as it involves the states, a little bit of blame shifting here after all is said and done. The states get to do the dirty work and handle the difficult measures. There's not the federal infrastructure really to do this, so these branch offices will have to struggle, particularly for past the first couple of years without any additional funding. But we can only push so much of this through, whether it's exchanges or Medicaid expansion. There's also an offsetting desire to keep some of the full costs off budget in difficult times. and therefore not overwhelm the current contributions of employer-sponsored insurance and take that off the table with early escapes. Next slide, please. Why is there such an ordeal of change in this transition, whether it's the standard battle between politics and markets or a blend thereof? Well, we've got a lot of repositioning in the business community, healthcare and broader. Somewhat of it's tactical, some of it's strategic to deal with the new terrain that they say we can stay in business, let's keep moving along regardless. But we also need to get beyond the common rhetoric of everybody saying they're doing reform, but actually carrying it out, particularly in the health delivery side. What we're seeing as the usual is the contrast between broad national goals and the fact that in healthcare markets you're still doing local trial and error to see what will actually work. So are all these experiments going to be scalable? Can they be replicated? Can they be adapted to the particular conditions? And that's an evolving story which is definitely uncharted thus far. Whether these models, on to the next slide, please. You know, we have all kinds of pilots. Sometimes it's for exchange coverage. Sometimes it's for other ways to do health regulation or delivery system reform. But there's three basic models here, and the first is the most optimistic one, which is kind of everybody flying in formation perfectly all synchronized, like the Blue Angel flying squad. Next slide. We have the alternative worst-case scenario of more of a World War II version of a pilot program in which it's more of a kamikaze style, landing on the target site where those who were observing it didn't realize they were the target when it landed. That's the USS Bunker there. But I bet in, next slide, please, more of a prototype, somewhat like this wiring diagram, which is rather complex. If you have to look all the way through in the fine print, it's pretty hard to find where that pilot-like mechanism actually is, let alone whether or not it will ignite and be able to perform on a steady basis. Next slide, please. There's some other roles for state policymakers and state governments, which is the things beyond what we just talked about to a large degree. A lot of state policy activity potentially in getting a better handle on re-influencing and changing the direction of the social determinants of health, a little broader portfolio of more imaginative investments on that front. Scope of practice comes up more at the state level in terms of the mismatch between the capacity that we have in the medical community and what are going to be increased demands on the system. Competition policy is often thought of as strictly a federal involvement, but there's some state factors in that as well in terms of concentrated local markets, particularly on the hospital side. Whether it's telemedicine or domestic version of medical tourism, the idea to expand the parameters of competition may come to the fore. And then look for some cross pressures on state and federal regulators under the ACA, where more and more of the marginal businesses in between sizes look to use self-insurance as a short-term escape from some of the regulatory provisions and some offsetting reactions by some state policymakers to try to close that door as a way to get around some of the rules for fully insured plans as opposed to self-insured ones. Next slide. Well, what are the choke points and leverage for those states who are less positive about the Affordable Care Act as opposed to embracing it? And there's a number in between as well. There's the battle between whether the exchanges are going to be state-run or as a backup or a default override federally run. Aside from what we've talked about before, there's also an ongoing legal challenge currently in federal district court in Oklahoma, challenging the IRS rule, which says that federal exchanges, whether you call them facilitated or federally run, can distribute the premium assistance tax credits. The feds will answer that complaint on November 19th, and there could be a early hearing on that in terms of a motion for declaratory judgment and preliminary injunction. Maybe even by the end of the year. This is a leftover of the older case that got paused in Oklahoma challenging the individual mandate. There's a conflict between the statute and what the regulations put out by the IRS say as to federal exchanges. The Medicaid expansion, it's more of an issue, not as wide as it would have been under a Romney administration, but whether governors who can hold out and ask for more operating authority and discretion might be able to get something back in the table in return for agreeing to the agreeing to the Medicaid expansion post-Supreme Court case. So I keep an eye on several of those key states for trying to do that. Eventually they'll come on board, but they may get a better deal than they would have otherwise. And then whether or not, I think repeal and replace is off the table, but the question is, as this unfolds, whether renegotiate and rewrite in order to have some capacity that works might become more of an issue. Get toward the end of this next slide. There's some are optimistic, some are less imaginative on whether or not we can pull off this implementation plan for health delivery reform, ACA implementation, and affordable entitlements. If you look at the missing ingredient in the middle of that equation, it basically is relying upon the fact that a miracle occurs, and we'll see whether or not it happens. Next slide, some quick predictive models, almost my last slide, for what are the possibilities, probabilities, and implausibilities of this going on. We exaggerate our political factors as to whether we're going to go off the rails and go to either extreme. I would suggest that, in fact, most of those forces are centripetal rather than centrifugal, and so there's a narrow zone in which we'll converge one way or the other. But changing the permanent law is what the ACA did for the larger healthcare world, has changed that frame of reference and changed the maneuvering room within that context. The accountability issue to politicians or patients, at the moment it's leaning toward politicians. There'll be some feedback on that, as well as the overrides of macroeconomic factors, as Mary Agnes mentioned. I won't go into the last slide, but that's just basically some bonus round stuff where you can find out a little bit more thought on this that suggests that it's not over till it's fully over, and there's some other chapters to play out on this front. Thank you very much.
Great. Thank you so much, Tom. We are going to change presenters right now, and we're going to hear from Judy Waxman. Judy, you now have control of the screen. Are you able to get going with your PowerPoint? We're seeing a conference call screen right now, so I could put up your screen if that's helpful.
Yeah, I think you'll have to. I just clicked show my screen, and it's
That's right. That's
okay.
right.
So if you could do it, that'd be great.
Okay. So then I need you to just tell me when you want me to advance, and I'll go ahead and do that. We now have your title screen up. This is Judy Waxman from the National Women's Law Center.
Okay, great.
I'm now on your first screen.
Thanks a lot. I was going to add one thing in here, just following up on the last speaker, and that is I would heartily agree it's never over till it's over. And in fact, if we really even look just at Medicare, people have said to me, well, do you think, over time the ACA will be tweaked, rewritten, changed, various things? And I would say, look at Medicare, in which I'm not sure there has been a Congress since 1965 where there wasn't some Medicare bill, tweak, change, addition, replace something, because, of course, our healthcare system is an evolving system. And so I expect the ACA to remain the law of the land and, of course, to get tweaked and rewritten and bolstered over the years, which I'm going to assume is what the rest of the panelists are saying as well. So I was really asked to talk about kind of what is this about, really, and looking at it from the individual point of view, and why are we doing this, and what kind of individual stories or changes in the law that are actually going to affect people as things that you might actually report on. So I start looking right here at women's health insurance coverage last year, which is the statistics we have. And again, to remind you that there are still close to 50 million people without health insurance, I look at this through the women's point of view, which is why you'll keep hearing me making that reference since I'm with the National Women's Law Center. But it obviously applies to men and some kids as well. So you can see the sections of this particular graph that are dotted are where there'll be the most changes made to people's insurance. But there will be some changes on the employer-sponsored insurance side as well, but the big goal, of course, is to fill in that gap and make this better, more comprehensive, affordable coverage. Next slide. And really, here's why on the next slide. Because when we look at it for women, we see that women do make about 80% of the healthcare decisions for their families, and yet we have many studies that show that more than half of women go without necessary health care because they couldn't afford it. Men do too, but women more so. And also women go without preventive health care because they couldn't afford it, as do men, but more for women. Next slide. So we did a report. Now, this is before the law was passed, and I go to this because this is what some of the problems are with our healthcare system and what this law is going to change forever. We looked at what we call gender rating. The only thing we had access to was individual health insurance, and we did a whole We actually did it 3 times over a few years, and we found that women are being charged more for health insurance in the individual market than men, to the tune of approximately $1 billion. That would be in the last time we did it for the coming year. 92% of the plans in states where gender rating is allowed do gender rate. A minority of states have any kind of limits. And as you can see, we looked at 25-year-olds, 40-year-olds, and 55-year-olds. And as one example, in the 25-year-old range, some women were charged as much as 85% more than men. And the variations were so broad and variant, really, across the country. You never could really say what this was about exactly, except one thing we did know was that it was not about maternity care coverage, because we only compared plans that did not include maternity care coverage. Next slide. So looking at maternity care coverage, we looked at every single individual plan that was available that we could find. This is, I should actually say, in each state capital that we did it, to compare state capitals. And you can see that only 12% of them included maternity care at all. And some of the plans that 226 of the plans that even offer the option of purchasing maternity coverage do it for a significant amount more. And maternity riders, as we call them, that means you can get maternity if you want to, which comes with all sorts of pre-existing condition limitations. Anyway, they're not cheap. Next. So this, I put this slide up just to show you that this was part of the campaign that we initiated as we were trying to encourage Congress to pass the Affordable Care Act, because it really was our contention, based on that report and other things that I talked about, that being a woman right now still is at being in a pre-existing condition. And we thought that that is something that we could change for all American women if we pass this law. Next slide. So I just want to go through this really quickly. You guys probably know how this works, but this is basically what the Affordable Care Act looks like from the individual person's point of view. There's 2 ways to get coverage. Some of this has been discussed already. Certain people can go in the exchange and they'll get tax credits so that they will save a lot of money on the plan that they have to buy. Up to 400% of poverty, which for a family of 4 is about $92,000 a year, I think, will get help in buying it. If your income is even lower, there will be Medicaid. And when we talk about the insurance reform, that's where we're going to get rid of gender rating as one thing, and also pre-existing conditions. So even in this election, which is so contentious, and I think we'd all agree ugly on the health care law, you had people who wanted to repeal the law say, well, we wouldn't get rid of that pre-existing condition part, which of course would be extremely difficult to keep if you didn't have point 3, which is the personal responsibility or individual mandate part. But what women are looking for really is a way to get affordable health care that they don't have to pay more for, that has, I would say, adequate, decent, maybe even good coverage. Next slide. And very quickly, you've probably seen this list before. It comes right out of the statute, but all of these benefits, and you might see there that on the 5th item, all plans are going to have to cover maternity and newborn care in addition to all the others. The 3rd from the bottom is preventive and wellness services, and I would say this is a new mindset, a new change for our healthcare system as well, that we are talking about now preventing illness instead of just being a system that treats illness. And there are many provisions of this law that make that leap. Next slide. Since I'm talking about women, I felt like I had to at least give you a heads up that these preventive health services are also going to be over time in everybody's health care package, and all of these services come with no cost sharing. So in terms, again, of women getting an advantage out of this law, the fact that all these services will be covered everywhere and no cost sharing is really an astounding improvement in the situation of health insurance for women. Next. So I was also asked to talk about, like, what are the challenges ahead? And, of course, we've discussed some of them already, but will all the states take up the Medicaid expansion? And I do believe, again, over time they will. It took all states 17 years to take Medicaid the first time around from 1965 onward. So I think that will happen. But obviously there are lots of issues for individuals in this as well as how the states, it is a complex thing to set up, but our whole healthcare system is complex. So what consumers need to look for, how Medicaid and the exchanges are coordinating so people don't fall through the cracks. How are the providers faring this, educating on what they're supposed to be doing for consumers. That goes for insurance companies too. We know the National Association of Insurance Commissioners is extremely busy laying out all sorts of guidelines and guideposts for insurance plans around the country, but consumers will have a lot at stake and a lot to look for, and I assume there'll be plenty of stories as that moves forward. We certainly will continue to evaluate, one in 2014, but obviously in many years to come, what are the cracks, what do we need to fix, and I'm sure there'll be plenty legislative fixes along the way, but some of these have already been mentioned. Massachusetts does tell us that there probably will be a need for new providers, and I do appreciate Mary Agnes mentioning that, in fact, the law contemplated that and is already on work on it, but we're going to be needing to look for this. Is care really being coordinated? Many provisions that promote coordination of care, again, from the individual point of view, we hope fewer of us will fall through the cracks of the current system. And then there's that, pesky holding down healthcare costs, which is something certainly Massachusetts didn't even contemplate. There are some things in the law, but we're always going to need to do more about that. Next slide, please. So I really just wanted to go back to having you all think about what really are the promises, and I do believe as the provisions have gone into effect, the public have gotten more used to them and like them, and as more go into effect, I think we will have that. Interestingly, in polls I saw that as soon as the Supreme Court approved the law, approval of it went up, which was kind of interesting. But nevertheless, we're in this for the long haul. That's what this is about. But in the long haul, this will change the assumptions about our whole system, that we are looking more at preventive care, that everybody's supposed to be covered by insurance and everybody's supposed to have a way to get decent health care in this country. It really is a very different mindset, that there is a way for us to move forward, or maybe I shouldn't use that, move ahead, advance, and really become a healthier, more productive nation. And this is one thing that, like, of course, from my personal point of view, it's high time we did. We have a lot of work ahead of us, and there's going to be a lot of personal stories about people who have gotten health care that couldn't before, maybe some that still fall through the cracks, and that will help us figure out ways to make it better. But we are on our way, and there's going to be a lot to talk about. That's it.
Well, thank you so much. This is really helpful, and I think what we're going to do now is try to take all these ideas and really transform it into some great story ideas, and we're going to turn to Anna Gorman. It's just going to take me one moment here because my little screen sharing thing keeps closing. So just bear with me for a moment here while we change over for a moment. Anna, while we get set up here, why don't you just start speaking, and then we'll work on getting your PowerPoint up in a moment.
Sure. Can everybody hear me?
Yeah, we can hear you.
Great. Thank you. Thanks for having me. So now that the election is behind us, there are fewer questions and uncertainty about the future of the law. And so I kind of see my job as a reporter to stop talking about what people think about the law and rather start talking more and more and more about how it affects people and what it looks like on the ground. And I'm not talking about, consumer stories, what this can do for you, but real tales of real people and places that are impacted and places that are challenged and people who are challenged by all of these changes. I took a walk with a girlfriend this morning who happens to be a doctor, and she just is completely overwhelmed and said the change is so fast that we can't even keep up. So for my few minutes, I want to talk a little bit about that, about how to find real people stories in all of this complex policy and how to translate the law for your audience and find good stories.
Anna, we have the PowerPoint up, by the way, so just tell me when to advance the slides.
Will do. So this first slide is actually a great resource, the Kaiser Family Foundation. For those of you who don't know about this, go on their website today because there's a ton of great information. But this is a cartoon, and I encourage you guys all to watch this. It's we're not going to play it right now, but go on your own time and watch it. And it's just a clever cartoon. I've watched it several times. It explains in very clear language what the law does for all of these different people and hospitals and businesses. And it's a good example of how our job as reporters, those people who are on the line who are reporters, have the same duty to kind of make this real and understandable. There's a few other resources. Stay on that slide for just a minute. There's a few other resources that people can look at that kind of help you understand, especially for those of you who are just starting to cover healthcare reform and health policy. There's a great book called The Quest for Health Reform, A Satirical History. It's actually a book of editorial cartoons that have been drawn about healthcare policy and health reform, and it's just fantastic. And there's a consumer reports guide, very short but very clear, called Health Reform, 7 Things You Should Know. Know that you have to understand this law better than your readers, or else your stories are going to be completely confusing, and they're not going to do anything for the readers. But the law does so much that we've been talking about, and my fellow panelists have been talking about, that almost any health story you want to write, whether it's mental health, whether it's health at an elementary school, whether it's a public health story about asthma, whether it's a story about a hospital, that the healthcare reform law changes something. So that's kind of neat. There's always going to be a news tag for your stories. All right, so let's move to the next slide. So these are just a few little reporting reminders. I mean, I try never just to write stories only on policy. I want to talk to real people who are affected, nurses, doctors, patients, parents, teachers, children, and we'll talk about, so think about where those people are, and we'll talk about that a little bit later as well. Always, you want to have that expert voice in there, but you don't want to only have that expert voice. And I bet if you look at the healthcare reform stories that have been written and broadcast, across the country since the Supreme Court upheld the law, not that many of them have real patients in there, and I think that is a disservice to our readers. So then, as far as the third point, to cut through the rhetoric, I suggest, and this is so hard, I think, in health writing, and I've only been writing about this topic for about 1.5 years, but it's so hard to cut through that jargon. I mean, what is an accountable care organization? What is a primary care medical home? I suggest that all of you print out your stories before they run and look for any term that you didn't know before you started writing about this topic and try to take it out. And that's really hard, but it will make your stories better. Okay, and then the last point on this is just look for where the money is going. There is so much money flowing out of the federal government on health reform that there are a ton of stories to be done on where that money is going. Follow it and get to the small program in a small community and tell a broader national story through that one small program, because wherever you are, in whatever state you are, there are the same things happening all over the country. And so it can be a microcosm for these larger changes that are going on in the health industry. Next slide, please. So let me talk about 3 different areas: ideas in where people get care, ideas in how people get coverage, and ideas in challenges facing people. And if you notice, all 3 of these areas have the word people in them. So I'm just going to beat a dead horse with that. Really try to get people in your stories. So in hospitals, just going to throw out some ideas. Hospitals are trying to reduce readmissions. So you could go to a local hospital and find out whose job it is to try to reduce readmissions. Do they have somebody going out into the community doing this? Do they have somebody going into each patient that keeps coming back? Is there a program for homeless patients and frequent flyers that is trying to keep them from coming into the hospitals? I heard a story just this morning on NPR about urgent care centers and how urgent care centers are going to start becoming the new ERs because hospitals won't get penalized. So maybe hospitals are going to start opening more urgent care centers. So that would be an interesting story. There's also a big pressure to improve patient satisfaction. So how are places doing that? And what changes are being made to help people be happier when they go to the hospital? Private doctors, there can be stories on how there's this culture change of doctors working more closely with hospitals. What does that mean for your random doctor on the corner? How is he having to change his practice to work more closely with a hospital? You can profile one individual doctor, spend some time with him. Emergency rooms, a lot of the emphasis on keeping people out of the ER is focusing on changing the culture. How is that possible? Can we change the culture of people who have been using the ER as their primary care for so many years? And there could be a story in how do you change that culture? Clinics, I'm currently working on a series of stories about community clinics, and there's just too much to write about there of all the change that's going on in community clinics, because they are the places where the bulk of the expanded Medicaid patients are going to seek care. So there could be a story in group visits. There's a rise in group visits of patients who all have one disease coming to see the doctor at the same time, or something about health coaches. Next slide, please. Michelle, thank you. Ideas in how people get coverage. So there's various ways that people can get coverage, right? Medicaid, exchange, workplaces, private insurance. I would add, should have added Medicare. And there are stories in all of these areas. So my fellow panelists have talked about some of the challenges with Medicaid. But again, try to think of what this means to people. So you could go to a safety net hospital and see what this will mean and what it is already meaning. If more people have coverage, then this could be a good thing for hospitals, right, for their bottom line, because they'll get more reimbursement. So perhaps there's a story to be told in an administrator who is balancing the budget and trying to make this happen, and trying to find good ways to increase the revenue. Also, safety net hospitals are having to go through a lot of changes to improve, because all of these patients who have Medi-Cal will have other choices. They will no longer have to go to the county hospital. So what are the county and safety net hospitals doing to make themselves more appealing to people once they have choices? Are they trying to cut down on wait times? What are the wait times now? What does an emergency room look like? And how long do people have to wait? And could that change? The exchange, we've talked about some. But again, there are real stories in this as well that don't have to do with just how states are setting them up. There's consumer groups and community groups are already getting started on trying to get the word out and trying to reduce confusion about the exchange and what it could mean to people. So maybe get inside a consumer group that has meetings on patients who are falling through the cracks and who could fall through the cracks if the exchange doesn't work as it should. Workplaces, workplaces and businesses some are going to face penalties for not providing affordable coverage. So maybe profile a small business and all of its employees over the last 5 years. Have they lost employees? Have they had to cut health? Have they had to increase the healthcare payments that their employees have to face? And what has that meant? Have they had to cut insurance altogether? And then is this going to provide a break for them and make their company more viable and make it easier to hold on to their employees? And get in there, get into that workplace and step away from the healthcare aspect and just what does it look like? What is this small business? When did it start? When did this guy start this business? And what do they do on a daily basis? And Medicare, I should have added onto this slide, there's a lot of changes going on to Medicare, of course. Just one example would be the dual eligibles. These are people, again, a word that you should not include in your stories because nobody knows what it means. But these are people who have Medicare and Medicaid. And there's a lot of effort to cater to these people to help manage their care more effectively. In California, there's a big push to get all these people into managed care. And what does that look like for, your 85-year-old grandmother who has multiple chronic diseases and has never known how to work through the system of both Medicare and Medicaid? Will it be better for her? Will it be worse? Next slide. And, next slide, please. And the last one is ideas and challenges facing people. So we talked a little bit about the challenges. There's many of them still out there. But we're going to, as reporters, we want to look for stories in some of these challenges. So we've talked a little bit about access, the second point, access to providers. There's going to be a huge shortage of providers. But you can take this and make it real. There's an effort to get veterans to become physician assistants. So maybe there's a story in there. The National Health Service Corps, which is a loan repayment program for people agreeing to work in primary care, is going to get a huge amount of money. So maybe you can go to a place where nurse practitioners train and find some nurse practitioners or physician's assistants and see how this is going to help them. Is this going to change their mind, or are they going to want to go to a place where they can get their loans repaid? And distribution of providers as well. So maybe you want to take a look at your city or your county or your state and see where are there providers, where are there not providers, where are there shortages now, and where are there expected to be shortages in 2014. And enrollment, that is going to be big, right? There's millions and millions of people who are going to have to get on to new access through Medicaid or through the exchange. So how many jobs are going to be offered to the people who are going to be doing this enrollment, and who's going to get them? Is the union battling in your local community to get those jobs? And then how are churches and community groups and other organizations going to reach out and try to improve and try to help people get enrolled as well? Obviously, those left uninsured is a big challenge, and immigrants, undocumented immigrants, are the biggest population of people. But what does the mixed family look like? Can you find a family where some people are undocumented and some people aren't? And so some people are going to get access to health insurance and others aren't. What does that look like? What does it mean for a family where maybe one sibling gets it and the other doesn't? And what kind of challenges? Is there fear in those families? And of course, there's other people left uninsured as well, but that's the biggest population. And then the cost for the states and the cost for individuals and families. There is a question of whether, even with the subsidies, can families afford to buy private insurance through the exchange? And so what is the debt going to look like? Is it going to help medical debt problems? Is it still going to be out of reach for a lot of families? Find families who are trying to make these decisions and will be making these decisions in 2014. And cost for states, too. Of course, this Medicaid expansion is a great thing at the beginning, but then it's going to cost states a good portion of their state budgets after, I think it's 2015, right? If I'm correct. So what does that mean? Here in California, we're having a special session of the legislature in December and January to address some of these issues, and the governor's going to decide what they can and cannot do. And look at also what it doesn't do. What does the law not do? One of the big areas is it may or may not truly address health disparities. And so what kind of stories could be there to be told? And there's also going to be challenges in the community transformation grants, another jargon term, another bureaucratic term, but these are those grants that are trying to make communities more healthy. So for bicycle paths and for parks and things like that. So how are these communities doing that? And is it possible? Is it really changing? Okay, next slide. I just want to show you a few. So I have hopefully thrown out a bunch of ideas that you guys can take back to your local communities and decide what to write about and explore these things. I just want to point out 3 stories which do an amazing job of what I've been talking about, telling complicated, complex health policy stories through real people and real places. Atul Gawande, obviously, you all know, is a pro at this, and this was, I think, his most recent story, which I just love, one of my favorites, and it took a close look at the Cheesecake Factory. And it compared the Cheesecake Factory to medical care and health care in America, and looked at whether the healthcare industry could do the same thing that the Cheesecake Factory has done, which is have high quality, low cost, and minimal waste, and be a very appealing place for people to go. So if you didn't catch this story in August, I encourage you to go back and read it. Next one. And the second story I want to point out is one that ran in the New York Times around the same time this summer, and it was about a nurse, a really close, intimate look at this nurse in rural Mississippi who is helping people stay out of the hospital. These are people who need more than just their primary care. These are people who need somebody going to their homes and to their bedsides. Also a really great portrait of a real situation. And then the third story, next slide, is one done by my colleague, Noam Levy, who works out of Washington for our paper. And he took a really good look at electronic health records. And we've all written about this, but this is one of the best stories I've seen on this topic. He went to an emergency room and showed what it looks like when electronic health records are not in place, and what the price and the cost to patients and to the hospital are when this doesn't work. So again, I also encourage you to go back and read this. And the next slide, the final slide, is just a list of some sources. And hopefully a lot of you know about these sources, but here's just a few for those of you who don't, and a few hopefully that people may not be as familiar with. And I think these slides are going to be accessible to you all after today, so no need to frantically write these down. But thank you so much, and I look forward to your questions.
Hi, all. Thank you so much. So thank you to all these really wonderful panelists. What I'm going to ask all of you to do, we've had a few people who have sent us questions already, and what I'm going to ask you to do is, if you have a question, you can either raise the question thing, you can type a question, or you can raise your hand on the dashboard on your screen. And I'm going to start out with a question for you, Anna, and also Judy Waxman, just so you know, from the National Women's Law Center, had to leave. Karen Davenport is replacing her, and she's the Director of Health Policy at National Women's Law Center. But why don't we start out with Anna answering this question. It's from Rob Waters, a former journalist who's now at the Prevention Institute as a PR person. And he asks about whether you think the Prevention and Public Health Fund, which has $15 billion in it, and which Republicans see as a slush fund, would be imperiled and what would happen to the early progress with those funds. So I don't know, while we kind of get set up, Anna, if you want to try and help us with answering that.
Sure. I mean, I think it's there is still quite a bit up in the air, as as the first few panelists talked about, and so I think we don't know what's going to happen to some of this funding. But the states, a lot of states are already moving forward. A lot of these grants have already been distributed, and so places are underway doing projects in their communities to improve prevention and public health. So I don't know what will happen to those funds, but I think that people should look in their communities and see where those funds are, what is already underway, what's already been changed. I know here in Los Angeles, a lot of that money has gone toward tobacco cessation, and there's a lot going on in that area, and I'm sure there are good stories there. Thank you.
So I don't know if any of the other panelists want to reply to this one. We have a number of questions here, but Tom or Karen or Mary Agnes, did you want to throw in a reply? You're all unmuted right now.
Okay, this is Mary Agnes. Basically, I think that the prevention fund is always going to be under attack for money. If you look back, and I'm trying to write a story about this, there was a particular agreement on some piece of legislation. I know I'll be very specific here. It's on our website, kaiserhealthnews.org. If you type in my name and prevention fund, you'll find it, where basically Democrats agreed to pull some money out of it to finance another piece of legislation, but Harry Reid, who's the majority leader in the Senate, said, oh, don't worry, we'll put the money back in over time. But, you know, it's going to take a while for some of the projects funded by the Prevention Fund to be able to demonstrate, if they in fact can demonstrate, their effectiveness. There's great debate about that, but I think that pot of money is constantly going to be under scrutiny from lawmakers who are looking for money to finance different things.
This is Karen at the National Women's Law Center. You can find on our website some pieces we've done, particularly blogs about the Prevention Fund, and want to focus on the fact that critics of the Prevention Fund often say, you know, this is about services that are already covered, and like mammograms and stuff, which is true. The Affordable Care Act does require coverage of mammograms, but at least from a women's health perspective, the projects that are funded through the Prevention Fund include some of the other major causes of death for women, particularly around heart disease and some other, you know, important diseases that aren't as easily addressed through other pieces of the law.
So I just want to mention we're going to take some more questions, that we are slated to have another half hour for questions. So just so all of you know, we're not ending right now, and we can keep going. I'm going to try unmuting Marla Miller. Marla, you're unmuted, so you can ask your question.
Oh, thank you. I actually didn't have a question. Did you think I did?
You've raised a little question queue here, so I'm going to try calling on Michelle Stuckey in the hopes that she has a question. If you raise your little question thing, it's like pressing the little button for the stewardess to come in the airline. So I'm sorry. Michelle, did you have a question? Okay, I'm assuming that's a no. So let's just see. I think we had a question from Sheldon Weisgrau earlier for all speakers. He writes, the discussion about Medicaid expansion, particularly from opponents, has focused almost entirely about direct costs to state Medicaid budgets. States also currently spend enormous amounts on funding care for the uninsured, either directly or indirectly, that presumably could be reduced with Medicaid expansion. There are also possible stimulative effects of large influxes of new federal money. What is the impact of these other factors, and who is analyzing and reporting on them? Anybody on our panel want to take that? It's kind of a chunky question. You want me to ask it again?
I would, yeah. If you could go over that question again, that would be great.
So it's about the Medicaid expansion, and this questioner says that the discussion is focused almost entirely about direct costs to state Medicaid budgets, and that the states also currently spend enormous amounts on funding care for the uninsured that could be reduced with the Medicaid expansion, and that there could be stimulative effects of large influxes of new federal money.
What is the impact of these factors, and who is analyzing and reporting on them?
Well, I see. This is Anna Gorman from the Times. I think, yes, there's going to be, because there's going to be so much influx of dollars with Medicaid, with more people getting Medi-Cal coverage or Medicaid coverage, and there is going to be a decrease in funds for disproportionate share funds, it's called, for a lot of safety net hospitals. But I don't know. I think the safety net hospitals, at least, are really worried about this because here in LA County, for example, there's still going to be millions left uninsured. So the county hospitals and safety net hospitals are really worried that they are not going to have enough funding to serve these folks. And so their hospitals here, at least, and across the state are, and I'm sure across the nation, are trying to cut costs and streamline services and get rid of unnecessary staff and unnecessary programs and cut waste to try to anticipate this cut from the federal government and disproportionate share funds. And I think there is a lot of coverage of this, but I would encourage you to look at the Kaiser Family Foundation, and they have a great resource on some stories that have been written, I think, on this topic.
Great, thank you. Did any of the other panelists want to reply to that?
Two factors. My recollection is if you go back and look at some of the post-enactment experience in Massachusetts, you found a lot of those safety net providers feeling like they were coming up short despite what seemed to be the coverage gains and somewhat of a reduction in emergency room admissions. So the demand reasserts itself in other ways, and I don't think it makes it go away and you don't end up with net savings. From the viewpoint of the states, there's two tiers to this. Although the expansive federal funding, at least in the early years of 100% federal funding for the expansion population is there, what many of the state administrators are concerned about is what this will do to their old Medicaid program, combination of the increased attention, mandates, et cetera, so that they'll be paying a lot more for their older program under the old FMAP rules, and therefore they'll be having a bit more of a budgetary bleed out.
Thank you. I have a question from Alma Martinez from Radio Bilingüe. She says, my question is, what is the best resource to find out the status of states' decisions on the exchanges and Medicaid expansion?
Well, I know that.
Yes, yeah. I mean, I think that you go to your own state Department of Health and Human Services, for lack of a better, that's a federal agency, but you know that they your own particular state sources might be faster and officials in telling you where they are in the pipeline for particular requests, waivers requests, or other decisions with HHS. I mean, the regulations coming out about to implement the ACA, those are available in a few places, and sometimes the HHS, the Department of Health and Human Services at the federal level, make an announcement when they've told whether it's a state or a particular entity, the hospital, the physicians, and so on, this is a regulation you have to follow. But I think if your state is seeking a waiver or a request or something, you know, it was trying to say, look, we'll implement Medicaid in this way, or this is the way we want to do the exchanges, I think sources at your state level, your local level, are going to be a lot more effective and faster in telling you that the federal government has said yes or no, or these are the changes that you need to make in your request.
I also have a suggestion. This is Michelle. There is an organization, I think it's called the National Council of State Legislators, and there's a woman there. You can get the correct name of the organization, but if you Google Martha King, she is the health policy person there, and they have a really great state-by-state, nonpartisan sort of update on where every state is, and Martha herself is a wonderful source. So I just want to throw that into the mix too. I have a question for Tom Miller from Deidre Baker. If the Virginia governor went for the federal exchange, what is the basic GOP-based reason for doing this, and will it impact other states with GOP governors?
Well, I think Virginia's not been at the front lines, unlike the court case and the individual mandate, of being as resistant to the exchange mechanism is of core of about another 10 to 15 Republican-leaning states. The basic strategy, although it's not going to be put above ground, I'm sure, is blame the other guy and it's your mess, not ours. So it was a default punt, at least in the early read, from Governor McDonnell, and not particularly surprising. Now, that can change over time. McDonnell is the head of the Republican Governors Association. Last summer took the stance on behalf of a number of governors saying basically, tell us more, you haven't told us enough yet. Of course, the reciprocal version of that is you're confining us too much and you've micromanaged everything. But that was to basically make it put the burden of going forward on HHS in terms of what the exchanges should look like. And there's still just a lot of uncertain detail as to whether these federal exchanges, how they'll come about. I'm sure they'll come up with some rudimentary thing. They've already let out the contracts. But to have the functioning effects of a federal exchange in a number of states is not a proven commodity thus far. And some of that's just a tactical move, I think, rather than a long-term strategic move by at least some Republican politicians.
Did any of our other panelists want to weigh in on this one? So I think we have a question from Emily Paulson. Emily, you are unmuted. Okay. So let me try someone else here. Shelley Gordon, seems to have left, so let me just see. I think Carolyn, no, she doesn't have a question. It looks like Deb Ross has a question. Deb, are you there? Okay. Actually, what Deb did is she sent us a message telling us the full name of the organization I had mentioned. It's the National Conference of State Legislators, and it's ncsl.org. And I'm just trying to see, it doesn't look like I can see a lot of questions here that we haven't answered. And I know that we have gone a little bit over an hour, so let me just ask our panelists, are there things that you feel like that you would want to almost comment on each other's presentations or remarks that opened up new questions or avenues of exploration in your mind?
This is Mary Agnes talking. I think that Judy's comment earlier that you can expect a lot of changes and twists and turns along the road of AC implementation is one that you can't forget, because I know from the Washington perspective, we're very focused on, I go back to 2009 and 2010 and following every single thing up at the Hill, and would they get it passed? Well, they got it passed, right? And then you had all the Supreme Court challenges, and that was the focus. And then the law, the court made its ruling, which had some surprises and some not surprises. And then now the big focus was on, oh my goodness, if Romney's elected, it could get repealed if you had a Republican-led Congress. Well, that didn't happen, and so I think in some people's minds they may think, oh, the big events are over now, and they'll just go ahead and implement it. But it's going to be a lot rockier and a lot harder, perhaps, than people imagine. And I think Anna's point about looking for all these human stories and how it affects people, because ultimately that's what proponents of the law would tell you. They did it to help. The president talked about in his acceptance speech the other night about, not acceptance speech rather, but his speech after being reelected, focused on a child who I think had had cancer and her family, and talking about that experience, that will ultimately be the success or failure of this law, how it helped or perhaps did not help the people that it was intended to benefit. And that is a story that is going to be told over the next 5 to 10 years, even longer, and 20 years out, the ACA could look a lot differently than it does now. So that's just something, I think, for people to keep their eyes on and ears on as they report on the implementation of the law.
Yeah, but not to be redundant, but I would encourage you not to just put a paragraph or two that so-and-so has cancer and this is going to help them get health reform, but really spend time with that family and what have been their challenges since the day that their child was diagnosed through today, and go with them to the doctor appointment and look at their medical bills and talk to the child. I mean, I think the more that we as reporters can put a human face on all of these issues, the more that our readers will understand what it does, this million-page law that most of us haven't read.
We have a couple more questions here. One from Marla Miller asking Tom whether you imagine that the GOP will continue to, I'm quoting here, obstruct the implementation of the ACA. What will be the GOP strategy? Do you have any thoughts on that?
Well, I don't think they're obstructing. They're just facilitating a better world ahead. But that's a matter of opinion, I suppose. Look, I think that the action is going to move away from congressional resistance in terms of, symbolic test votes or other types of things. I think there will be a continued tug of war at the state level, not only between Republican-oriented states and the national government, but even within those Republican states, sometimes there's some tensions between the governors and the state legislators and the grassroots activists, and that story is not fully told. The story that's not been also told by almost any journalist is actually talking to the people in those states as to why, as opposed to the standard story, how wonderful this is, why they might have a different point of view on that, and that tends to be an unreported exploration as well. So I think that what you're going to see is the opposition to the ACA is going to have to switch from being ideologically based to being evidence-based, and that will be more in evidence in the 2014 implementation run-up and the early unfolding of this, and that will change some of the parameters of the debate.
I think that's really a great answer, Tom. Does anyone else want to weigh in on that? So we have another question from Kelly Tyrell, who says that she's heard over and over in her reporting that physicians are worried about the way that the Affordable Care Act changes the way they practice through structures such as the Independent Payment Advisory Board, payment reforms, patient-centered medical home, and EHRs. Are there reasons to think the average private physician will see major changes in how they practice and how they get paid? And how should we think about and approach stories focused on these changes as the ACA is implemented? Now, let me just say before folks answer that there's a lot of terminology here, and this is a huge question. So maybe let's just try to tackle a piece of it, but Kelly is willing to hear from any and all of you.
This is Mary Agnes talking. I think that one way to go about that story, and a lot of these are unanswered questions, no one knows, but looking at what the law is requiring physicians to do, and then how physicians are perceiving that, and what does that mean? What does that mean in their practice to have electronic medical records? And I can't remember off the top of my head what all the provisions are. I think that they being the government wants more reporting in Medicare from physicians. They also have an overall goal of trying to base payment based on the quality of medical care provided versus the number of services. I mean, in the fee-for-service system, which is where something like 75% of Medicare beneficiaries are in, if you're a doctor or another practitioner, many of the incentives are driven to do more and more care. And the thought is that they want to increase payment for better care, but what are they requiring of doctors to get there, and how are doctors coping with it? I mean, a patient-centered medical home, the idea that someone would be looking at all your medical records and all the care you have and coordinating that, people like that idea, but does the law and the payment system adequately reimburse a doctor for doing that? I mean, these are sort of those unanswered questions. This is done through the physician's point of view, the questioner, but as this law is implemented, I think reporters have to look at hard questions like, is it reducing costs? Is it increasing costs? There's criticism that the essential benefits package that I think Judy had on one of her slides, all those things that must be covered, all those categories, will that increase healthcare costs? You know, what's going to be the cost of health insurance in the exchanges? Even with a subsidy, is it too expensive? I mean, as this unfolds, whether it's a physician eyeing it and what does it mean to his or her practice, or someone trying to buy coverage in the exchange who on the individual market couldn't swing it, are they going to be able to afford it in the exchange? That's the kind of rubber hitting the road story that reporters are going to have to wade through and try to explain to their readers.
Did anybody else want to weigh in on that one?
Doctors will be paid less and they'll be working for someone else, but I think the ambitions of the performance-based payment in the early going. You just saw them pulling back on the size of the medical groups to which that would apply in the initial years to be larger groups. It's going to be harder to drill it down to the smaller cohorts of doctors, except in the big medical groups.
But there has been, this is Anna again, there has been over the years kind of the disappearing family doctor, right? Family doctors have had to see more and more patients in a day, and they're getting less and less reimbursement from the public programs and from private insurance. So a lot of family doctors have gone under or joined practices. So perhaps there's a story in one doctor who's making that choice of giving up their practice for so many years and joining a big organization where they are suddenly kind of a number rather than the name and the guy who has had the same families and the same patients for 40 years. And how easy is that change to make? And what about a doctor who is 65 and has never used a computer with regularity in the office and now is being forced or is having to move to electronic health records? What is that? What challenges does that present? And what do you do with all of those medical records and all those papers? And where are all those papers going? From what I've observed from electronic health records, obviously it's better for coordination of care. But maybe we, as reporters, we should try to prove whether indeed it is. I'm not sure how, but try that. But is it good for patient-doctor communication? Doctors are looking at computers rather than their patients, and maybe the conversations aren't as strong, and maybe the doctors aren't getting as much information from the patients as they would have in the past. So I think those are all just things that you're going to see when you're in a doctor's office. I mean, you can call doctors and ask them. You can ask experts. But again, if you just go and spend time with doctors, you're going to see, I think your question is going to be answered loud and clear.
I think that's a really great idea for a story and a way to really to witness it as it unfolds. I had a question from Barbara Fader-Ostrov for all of you about just keeping up with developments and for the journalists finding the human interest, the protagonists that you're looking for in your stories. How much all of you are using social media and Twitter and Facebook to either keep on top of trends or to find those stories that you need to bring your reporting to life.
I love watching what other people are writing. I mean, I think that in this day and age, we should get ideas from one another. I think there's less and less competition out there among journalists and more collaboration. And reporting on health is a great example of that, of course. So we should just keep up with what other reporters are writing, and you can do that through Reporting on Health, through the Association of Healthcare Journalists, through Twitter, through Facebook. Just watch what people are writing. The Robert Wood Johnson Foundation puts out a great several sets of lists. Also the Kaiser Daily Health Report, California Healthline here in the state. There's a lot of organizations that are putting together lists of good stories.
Practical question from Christy Nelson. I'm sorry, did any of you, other of you have an answer to that? Mary Agnes or Tom, are you
it's just me. I just was saying Twitter's great. This Mary Agnes, Twitter I think is the fastest way just to learn a lot of all the stuff Anna's talking about. It just seems faster, easier to access, and I have it up on a screen. Got a dashboard there, and try to follow a lot of people on both sides of the ACA argument or whatever you're pursuing, and I think you'll get a much broader presentation of ideas.
And how about you, Tom? Are you a Twitter fiend or a Facebook?
I don't give a tweet.
We have a question from Christy Nelson. What is likely to be the second largest group of uninsured after undocumented immigrants?
You know what, this is Mary Agnes. What I wonder about is if, and I don't know what these numbers are, but if you have a governor that does not want to expand Medicaid, for example, right, and if they stick to their guns, they don't want to do it, people between 100 and 138% of poverty could get help through the exchange. They could get a subsidy and buy health insurance through the exchange if that subsidy were generous enough. But if you go below 100% of poverty, those folks, as the law is now written, they cannot go into the exchange. And so they may already currently be uninsured. Maybe they're not a growing number, but it would be an incredible irony if some of the poorest of the poor, if there weren't a state program to benefit them, if the ACA couldn't help them get coverage. I mean, I think that's kind of it's a very interesting story. I don't have numbers in front of me on it, but it's a part of this story that has been somewhat overlooked, but it's a wrinkle in what the Supreme Court decided and how the law is written, where you could have some very poor people not get coverage.
There's a few other categories too. I think people, and I think I mentioned this, people who may qualify for subsidies under the exchange but can't afford the premiums anyway. And if you look at your state exchange, if it's gotten underway at all, they should have lists of what premiums would be based on family income. So there might be a lot of people who remain uninsured because of that. And then there's going to be this whole, the people who are disconnected from the system. I mean, here in our state, there are a lot of people who are eligible for Medicaid but don't have it and never had it. And so they're disconnected now, and they probably will remain disconnected. A lot of mentally ill folks, a lot of homeless people, people who just are poor and do not know how to navigate the health system. I think there's a concern that a lot of them will continue to remain uninsured even though the law allows them to become insured.
I have a follow-up question here from Kelly Tyrell about the social media. She asks, when it comes to keeping up with developments, are there any recommendations you have on hashtags or individuals or groups that you follow and that you find useful? And I'll just throw in, I think it'd be useful to give some suggestions on both sides of the aisle and on the policy wonky front, too.
You know, Michelle, that might be something that we could compile a list
okay.
and send to you
yeah.
and send out, because nothing's coming to the top of my head, but on my Twitter screen of followers, I can pull some off and send them to you.
That sounds great. And by the way, Anna shared the resource that she had mentioned earlier. The cartoon book is called The Quest for Health Reform, A Satirical History. I think we may have a question from Deb Roth. I can't tell. So, Deb, I'm going to unmute you. And if you're still there with a burning question, please ask it right. Okay. I'm going to guess that means no. So, folks, any other final questions or comments or thoughts among our panelists? This has been a really vibrant and interesting discussion. Anything else that you wanted to add, even if it's just a final parting remark to our audience?
Thanks for listening in.
Tom, do we have a quip from you? I feel like we need a quip from Tom.
I've got to go on to another meeting, so I'm between quips.
Okay. Well, I want to thank all of our panelists. We've had here Mary Agnes Carey, Senior Correspondent at Kaiser Health News, Anna Gorman, staff writer for the LA Times, Tom Miller, Resident Fellow at the American Enterprise Institute, and Judy Waxman, Vice President of Health and Reproductive Rights at the National Women's Law Center. We're going to put everybody's PowerPoints up, and we'll have the webinar recording up a little later, if not today, but then by tomorrow. You can find additional resources on all these topics on reportingonhealth.org, including a blog post today with some resources by Trudy Lieberman of Columbia Journalism Review. If you want to tweet this stuff, our hashtag is ELEXHealth, all one word. And, thank you again to everybody, our panelists and our wonderful audience for joining us.